Welcome to Mastery on Guideline Ultrasound and Echo.
We have four main acoustic windows for transthoracic echocardiography: left parasternal, apical, subcostal, and supraesternal notch. But as we know, wherever and any spot that sound can pass through and get to the interest area, we can use it as an acoustic window. For that reason, we can sometimes use right parasternal, right upper quadrant, and we use lever as an acoustic window, especially when we don't have very good IVC and aorta and subcostal, or even sometimes based on the patient and situation, rarely we can scan the patient from the behind, from back. But we are not going to talk about those other acoustic window in this presentation. For parasternal lung access, as we know, some part of the heart is not covered by the lung that we call cardiac notch. It's almost at the level of the left sternal between the third and fourth intercostal space. That is the best spot for the scanning of the heart in left left parasternal. But when we turn the patient to the left or right, this spot will be changed a little. Just keep in your mind. The position of the patient for parasternal lung access left, the classic is left lateral decubitus, almost 45-degree patient turned to the left, and left arm, we put it high on their head or next to your head. The reason we want to make expanded intercostal space at that area. As you know, especially when you work in the hospital, many patients cannot turn. They have some restriction for many reasons, like they had post after angiogram, coronary angiogram. The patient for a few hours cannot turn to the left or right, or for any other reason, sometimes we have to scan the patient as a supine. In those cases, if the patient situation let us, we elevate the head side to 30 to 45 degree. That may push the heart a little closer to the chest. And even if you notice, some patient may become and they are in sitting, like wheelchair, and it's very hard to take them to the bed, or they cannot lay down on the bed. So we have to scan the patient in a sitting position, or even sometimes standing, and you will notice when you're working. But the most important point is that you know how the relationship of the heart and acoustic window will be in any position. Even in the classic position, maybe we need to turn during scan, turn more to the left lateral, completely turn the patient to the left lateral, or a little more flat. It's dependent how we get image, and you have to be very flexible the position of the patient, and keep in your mind that affect a lot on quality of your image and finding good windows. The technique for scanning is two-way, is left hand or right hand. In right hand, the tech sit behind the patient and start scanning with the right hand, and with the elbow and other hand, we can change the position of the patient very easily. And most of the time, it's used in the Europe country, because as the matter of the HIPAA, in the United States, they don't usually do in right hand, but that's fine. It is not against the law. And the common technique for scanning of the heart in transthoracic is left hand, that we sit on the left in front of the patient, and we scan with the left hand. I want to emphasize one important thing as a tech. If you are working as a tech 8 hours, 5 days a week, always try get a comfortable position and ergonomic chair that help you, and your shoulder, neck, and your back is in the neutral position. As we know, parasternal lung access in parasternal lung access view or PLAX view is a cross section of the right cross section of the heart in lung axis of the cross section of the heart. As you see here in this real photo of the heart that we cut in lung axis in PLAX view, the sound wave, the plate of the sound wave, pass through the lung axis of the heart, one side from the middle of the aorta and another side middle of the left ventricular through the apex. And our probe direction is the marker toward the almost between 10 and 11, or pointing to the right shoulder of the patient, and our probe is perpendicular to the chest, somewhere between third and fourth intercostal at the left side of the sternum. We start with that spot, but as a good technique is finding a best windows for PLAX view is searching circular, clockwise or counterclockwise, doesn't matter. And this maneuver, when we found the spot that has the best penetration of the sound to the heart and less the noise and the best quality of image, then from that point with maneuver, heel toe, rotation, fanning, all those maneuvers with the probe that I talked in another presentation, we fix our image. As you notice here, the photo of cross-section of the heart in lung axis, it looks like a little different with the ultrasonic image of lung axis of the heart in the PLAX. Why this is too much differences? The answer is very easy. As we know, in photo, we create image not only from 2 dimension, we get through some light from z-axis too. In other words, camera create image in the depth dimension or z-axis, but ultrasound only create from cutting surface, not the depth dimension or z-axis. In this photo, the camera create image on the wall of the aorta too, or here aortic valves, inside of the RVOT, some trabeculation, left ventricular, wall of the left ventricular, internal wall of the left ventricular, or papillary muscle that is not at the level of the cross section, or left atrium wall inside, and so on, and left that is mitral valve leaflet. So that is the reason. Ultrasound only create from cutting surface, not the depth or z-axis of the cross section. That is the reason it looks like a little different, but in reality is the same, only ultrasound doesn't create image because the sound doesn't pass through to those area, only this area sound pass and create image from this cutting surface. The structure, as you see here, we will notice in the PLAX view is RVOT, free wall of the right ventricular, RVOT, free wall of the right ventricular. This maybe you don't see very clear because of not optimized very well this image, and we have near field artifact. Then we have IVS, interventricular septum, anterior wall of the aorta, 2 cusps of aorta, anterior and posterior. Later we talk which one is that, each of them. Then posterior wall, anterior mitral valve leaflet, posterior mitral valve leaflet, some chorda tendinae here. We will see hyperecho line, left atrium, and thoracic aorta, descending thoracic aorta here. And here a hyperecho line, very hyperecho reflective thick here. This is pericardium. The first image we get in the parasternal lung axis is far field PLAX. And the purpose of this view is evaluation for any fluid around the heart. Is that any fluid? We know there is two processes can happen in the thorax around the heart. One is pericardial effusion and another is pleural effusion. The best criteria for differentiation between these two fluid from each other is relation of them with the thoracic aorta descending. If the end of the fluid packet is anterior to the aorta like this, it will be pericardial effusion, PE. If end of the fluid packet is at the level of aorta and beyond posterior to the aorta, it will be pleural effusion. As you see in these clips, we have here a large packet of the fluid here, posterior to the posterior of the heart, and we will see some echogenicity inside of this fluid packet that can be any like tissue like the collapsed lung or other material like the pus, blood clot, depending on what pathology create this fluid. This packet ends posterior to the aorta, so this will be pleural effusion. Even if we look at more accurate to the atrioventricular junction here, you will see a wedge shape during the systole, a wedge shape hypoecho or unecho structure here, that it gives us this fluid is pericardial effusion, and the top one is parietal pericardium, and the posterior one is this is the visceral, and the posterior one is parietal pericardium layer. In this another clips, as you see, we have both fluid. That this one is anterior to the aorta, so this will be pericardial effusion, and the other one is pleural effusion. After we rule out any fluid around the heart, the image is a classic PLAX view. As you know, a good PLAX view should have these features. First of all, the distance of the probe to the interventricular septum and anterior wall of the aorta should be almost equal. If it's not equal, just with heel toe we can fix this problem. Second, aortic valve should be almost roughly at the center of the image. If it is not, just we slide the probe toward the shoulder or toward the aorta. It means slide the probe to the midline toward the shoulder and in the lung axis, at the direction of the lung axis of the footprint a little, automatically this aortic valve come closer to the center. But if the aortic valve here at the left of the image, just we slide our probe toward the apex of the heart down. Another criteria for a good and correct PLAX is that the left ventricular, the proximal 1/3 of the left ventricular should be rectangle on diastole. As you see here, this part of the left ventricle during diastole is almost rectangle. In other words, this part of the IVS and posterior wall is parallel to each other during diastole. It shows us that our PLAX axis on the PLAX is completely passed through the center of the left ventricular. This line, that is the same for apical 3-chamber view too. And another one is that the LVID, left ventricular internal diameter, during diastole is the largest one. For getting the largest one, our plane of the sound should pass through exactly at the center of the left ventricular on the PLAX. If our sector passed through this slide, any above this line or below this line, you will notice the LVID will be shorter, and so we are underestimating our image. So when we are scanning, just we needed slide or fan the probe to the mid and lateral, medial or lateral, and see which spot give us the largest diameter when during real time we scan the patient. That spot will be correct for our access in the PLAX. Another factor that it give us we are in the correct PLAX view is that left ventricular at the end of the left side toward the apex will not be closed. If during systole it closed, most probably if the patient has very hyperkinetic left ventricular, the ejection fraction is very high, almost over 70, or most of the time we are off the axis. And the reason for being off the axis, we're twisting, our probe is twisting less than should be or more than should be. We are twisting probe clockwise too much or counterclockwise too much. How we know which way we twist our probe that it close the apex of the heart? If at here RVOT, we see RVOT open more, and we see a little of the pulmonary valve and pulmonary artery, we are twisting too much close clockwise. If opposite way, we will see tricuspid valve more, and we don't see very clear left atrium, left atrium very well, so we are twisting less. Just with that matter, we can keep it our left ventricular open. If we slide too much medial, the tricuspid, some part of the tricuspid leaflet show up here. So it give this idea that we are too much to the midline. We just slide more lateral or fan more lateral to the left of patient. If we are fanning or sliding too much to the left of patient, our LVOT will be start closing, and we don't see LVOT anymore. So we know we are closing, we are fanning too much to the left of the patient. And another one that is criteria that it show us we are in the right image, we have correct PLAX view, is that coaptation of the aortic cusp is at the centric. In other words, we have concentric coaptation or closing aortic cusp. The line that these two cusps contact each other is at the center of the aorta. If you look at here in this real image of the aortic valve, on PLAX, our plain sound, ultrasound wave, pass through this yellow line, yellow by arrowhead. This is right coronary cusp, this is left coronary cusp, and this one is non-coronary cusp. Our sound wave plate passed through the center of the right coronary cusp and between these two left and non-coronary cusp, the commissure of the left and non-coronary cusp. With this explanation, we know this anterior cusp is right coronary cusp, and the posterior, dependent of the heart activity or our hand angling a little left or right, the posterior one can be left coronary cusp or non-coronary cusp. Just keep in your mind. If our coaptation is not at the center of the aorta, in other words, coaptation is eccentric, this line you will see a little closer to the anterior or closer to posterior. We call it eccentric coaptation. If it's eccentric, it can be for two reasons. First, we are off the axis. You notice in this red arrow, if we are a little angling too much to the left of patient, we are cutting the heart. Our ultrasound plate pass through these two, and they are very close. So closing and contacting these two cusps is close to the anterior wall. So if we are fanning too much to the left of patient here, so we are getting posterior coaptation. So we have eccentric to the posterior. With this, one of the reasons that is eccentric coaptation is we are off the axis. Another reason that it can be of eccentric coaptation is when the patient has bicuspid aortic valve. That I'm going to talk about this in another presentation separately in detail. Another important issue that I would like to mention in this PLAX view is the name of this wall. We called it IVS, and usually we don't call it septum. Even this is septum, interventricular septum, but we don't call it interventricular. We don't call it septum alone in the PLAX view. Why? As you see in the cross section of the heart in this short axis, this part of the left ventricular muzzle of myocardium here is IVS, or interventricular septum. That is common between the right ventricular and left ventricular, interventricular septum. This wall is divided almost two parts. This like anteroseptal, anterior part and posterior part. The anterior part we called it anteroseptal wall, and to the posterior we called posteroseptal wall. As you know, the blood supply for each this segment is completely different. Anteroseptal supplied by LAD, left anterior descending coronary artery, but posteroseptal is supplied by 2 or 3 different coronary branches and involve motion and evaluation for all ischemic heart disease. So the differentiation between these two walls is very important. That is the reason under PLAX, as you notice here, our plane passed through anteroseptal and posterior wall. Sometimes we call it inferolateral wall or posterior wall, this part, this posterior or inferolateral wall. And to the septum here we called it IVS, or more accurate, anteroseptal wall. In apical 4, our plane passed through to this line, so to the anterolateral and posteroseptal wall. That is and in most people, when they call the septum, they mean in apical 4 view, apical 4 chamber view, and the septal will be posteroseptal wall. Just keep in your mind these little differences. Sometimes if we angle too much to the left of patient, maybe on the posterior of the left atrium, we will see a duct 1 or 2 go join to the left atrium, that they or they can be pulmonary vein, both one of them or both of them, left upper and lower pulmonary vein. Then is not pathology. Don't confuse it with the pathology. In some patient, maybe we will see between the here at the junction of the aorta, posterior wall, and LA, some circular structure, circular structure at this area. That will be right pulmonary artery, and is not pathology too. Another structure that sometimes we maybe see in the PLAX is coronary sinus. Coronary sinus run in the atrioventricular groove here, the junction of the atrium and ventricular. This part we called it groove, and coronary sinus pass through all around the base of the heart and join to the an entrance and drain to the right atrium. In some patients, this coronary sinus is prominent. Generally, when you see a coronary sinus prominent, measure it. If is the diameter of the coronary sinus is more than 5 millimeter, you have to think about some venous anomaly that at top of it is persistent left superior vena cava. For example, on this patient, the coronary sinus is very dilated and almost bigger than left thoracic aorta, descending thoracic aorta. Coronary sinus can be detected in different view too. One of them is in their RVIT view or tricuspid on the PLAX. Here we have tricuspid valve. This is a septal posterior leaflet, and this is anterior leaflet of tricuspid. Posterior to the posterior leaflet, here a wedge shape during heart activity. You can see even a duct, wedge shape here, and even duct. This is orifice of the or entrance of the coronary sinus to the right atrium, and posterior to that we see a line, thin hyperecho line. This is Epstein or Epstein valve, belong to the IVC. Sometimes we will see in some patient, and this is IVC inferior vena cava, and here we will see SVC superior vena cava. In apical two chamber, we can see coronary sinus 2 at the atrioventricular junction again here. In apical 4 chamber basal view, when we have apical 4, if we fan the probe toward the bed, we can start seeing basal view, apical 4 chamber basal view, that it show us this coronary sinus vein here as a duct and opening to the right atrium, or even maybe we can see in subcostal 4 chamber view too. And about this kind of anomaly, I am going to talk in the part 2 of bubble test study in detail. After we get in good PLAX, we go for doing M mode at 3 spots: left ventricular, mitral valve, and aorta. The most the most important factor that we do M mode on left ventricular correctly is that our cursor be perpendicular to the left ventricular axis, long axis of left ventricular. Our cursor should be perpendicular. For example, on this right side, as you notice, this cursor is not perpendicular to the left ventricular axis. As I said, the third part of the proximal part of the left ventricular, IVS, and posterior wall are parallel to each other, and this part of the both wall are exactly parallel to the left ventricular long axis. So our cursor should be perpendicular to those walls. If not, we never do M mode on left ventricular, and we never measure because we are overestimating all those parameters. For fixing that problem, we have two options with heel toe and sliding, or we just change the direction and location of the cursor and make it almost perpendicular to these two walls. Then we can do for rely on our M mode and measurement. The spot that we use and put cursor in any spot from the tip of the mitral valve leaflet to the papillary muzzle, because this part is rectangle and any spot we put cursor will be correct. For measuring, we measure at 2 times, diastolic and systolic. For measuring the wall thickness, we have to put cursor over the endocardium and over the endocardium, on the endocardium, not beyond that, not inner, just exactly over endocardium. As you see, two hyperecho line, the right ventricular side of endocardium, this is IVS, and this is posterior endocardium, or left ventricular side of the IVS endocardium. And for posterior wall, just remember we don't include chorda tendini or papillary muscle. As you notice in this 2D image, anterior to the posterior wall, we have a hyperecho line that is a chorda tendini that on M mode we can see as a hyperecho line separate from posterior wall. You see here hypoecho between these two parts. So we know this is chorda tendini. We don't include that one and this one, and just we measure real myocardium thickness. Then we go to at the maximum systolic thickness of the true wall and the LVID at the systole. In this case, our machine will calculate ejection fraction based on cycle and technique, and almost if we do correctly this way, that measurement will be almost close to our measurement in Simpson for apical 4 and apical 2 chamber. After left ventricular M mode, we do M mode on the mitral valve. We put our cursor at the tip of the both leaflet, the way that our cursor direction should be almost parallel to the direction movement of the anterior mitral valve leaflet. If it's not, our measurement again will not be very accurate. The only measurement we use for mitral valve leaflet is EPSS, E-point septal separation. That is we have M mode of the mitral valve. We have two main waves. One, the beginning, we call E or early feeling or early diastolic, and then A wave or atrial contraction or active feeling. And then we only measure this distance between the top of the E to the septum, this spot. So this will be EPSS. After mitral valve M mode, we go for aortic valve M mode. For aortic valve M mode, our cursor should be perpendicular to the both anterior and posterior wall of the aorta and should pass through the sinus valsalva of aorta and can catch the coaptation of aortic valve. We will get such diagram of the M mode. This hyperecho line is coaptation of the aortic cusps and represent diastole, and here starts systolic and they open and they get separate from each other. This one anterior and posterior one. We have three parameters for measurement in aortic on aortic valve M mode. The first is aortic root diameter. Aortic diameter, for that matter, we just before opening we put cursor the leading edge to the leading edge, or outer to inner. Outer to inner. Then we go measure how much those caps separate and separate from each other, and valve open at that spot. From here to here we call ACS, or aortic cusp separation. And the last one is LA minor dimension or axis. For that matter, we go at the end of the systole here, or largest diameter at this area that belongs to the left atrium. Leading edge to leading edge or outer to inner. We don't include the thickness of posterior wall of the aorta. Just we put here to endocardium here. As you notice, our cursor for correct measurement for both side aorta and left atrium should be perpendicular to not only to the aortic walls, should be perpendicular to both walls of the left atrium, anterior and posterior. You notice here, this is perpendicular to the aorta, but not perpendicular to the left atrium here, and the correct way should be perpendicular this way. But if you notice, this amount almost is the same as this one. almost the same. So we can rely on that measurement, but if too much of access, we don't measure the third dimension, that is LA. If for any reason we cannot get good mode on the left ventricular, we have to do measurement in 2D. For 2D measurement, we do in two different times, endiastolic and systolic. For endiastolic, we go and cine loop and at the level of the Q or R, wherever that has clear and give out clear endocardium at two valves and has largest LVID. Then our measurement should be perpendicular. The line of the measurement should be perpendicular to the IVS, posterior wall, and left ventricular axis, the way we measure it. And again, we don't include the papillary muscle or chorda tendini. We have to make sure we are not including them. If you are not sure, just cine loop and go back and forth and find the correct right endocardium line and then go that spot and then measure it. Another measurement that visually we don't do, only in cases we have pulmonary hypertension or right side problem, we measure it RVOT diameter. This RVOT diameter, we measure it if our has good and correct PLAX view. We measure inner of the right ventricular free wall at the level of the perpendicular to the aortic valve junction to the left ventricle at this spot. So the best and correct way measuring for RVOT diameter is from here to here. And this one is not correct, a little overestimating. But since our dimension measurement is in one line, just you have to keep, if we cannot get it exactly the same line, make sure your measuring is almost equal to this distance. And then we do for at the systole. At the systole, we don't need measure thickness of the wall. We just measure LVID at the systole time. Again, our measurement should be perpendicular to the left ventricular and exactly the same spot that we measure LVID at the diastole. Exactly, we have to do the same spot at the systole time, and don't again include chorda tendini or papillary muscle in our measurement. In that case, our measurement ejection fraction by technique will be almost close to the Simpson technique. After that, we go measuring the most important parameter in echocardiogram, and that is LVOT diameter. LVOT diameter is any spot for measuring. We can use any spot from aortic valve hinge to 5 millimeter toward the left ventricular, from the root of the aortic root to 5 millimeter to the side of the left ventricular, here to here, any spot. From here, we can measure here, here, here. Should be the same because that spot almost is rectangle too, and for many other reasons, as I talk in aortic stenosis, the best spot is 3 millimeter close to the aortic root. Our measurement should be done at mid-systolic or the time that give us the maximum diameter. Highest diameter, that will be take as LVOT diameter. The measurement should be inner to inner. This image is a little wrong. This has been measured outer to inner, so we measure inner to inner. And we have to try, especially when we have aortic valve stenosis calcification here, we have to do this measurement different 2 or 3 times in different angle, a little off axis, slide or move your probe a little higher or lower intercostal, and see which one will give you the best and highest diameter. Then take that one as LVOT diameter and delete the other measurements. After LVOT diameter, we go for aortic root diameter. Aortic root diameter, usually when they talk, is the aortic root diameter at coronary sinus of Valsalva. As you know, sinus of Valsalva is the area of aortic root that coronary artery orifice are at that spot, and usually is the largest diameter at the aortic root. We measure at the end of the diastole when it's closed, aortic valve is closed, and we measure outer to inner or leading edge to leading edge, outer to inner. As you know, actually, aortic root has 4 diameter, not 1 diameter. Aortic root is a part of the aorta, the beginning of the aorta that contain aortic valve. As you see here, this green, this is aortic root from the beginning to the above the coronary sinus and connect end of the aortic cusp here. Aortic root has 4 dimensions. One of them is sinotubular junction, the connection of the aortic root to the ascending aorta, this spot. That is the smallest or narrowest of the aortic root diameter. Again, we measure at the diastole, leading edge or outer to inner at the diastole. This measurement has been not correct done in the right moment. Then another one is the same as aortic root we talked in the previous slide, and we measure largest one outer to inner. Again, this one is not right. Outer to inner. This is aortic root diameter. Then we go measure 2 other diameter. These 2 other diameter, we called it annulus diameter. That a little difference. As we know, the lower part of the aortic cusp that connect to the aortic wall, we call it hinge. This is spot, hinge of aortic valve. The lowest part that connected to the aortic wall. If we measure aortic side of the hinge to hinge, inner to inner, we are measuring surgical annulus diameter. So, aortic side of the hinge to hinge is surgical aortic annulus diameter. If we measure vertical side of the hinge to hinge, inner to inner, we are measuring echocardiographic aortic annulus diameter. For memorizing those important parameters, we can take it as a phone number, memorize it as a phone number. There is male and female. Our measurement for each of those parameters should be less than these numbers. 11 is when for memorizing better, you can memorize as the number you have to call for out of the United States. You have to first take this 11. So for both of the men and female is the same. For and it should be IVS diameter and posterior wall diameter. Both of them at both genders should be less than 11 millimeter. For the left ventricular and diastolic diameter for men should be less than 60 millimeter. For female should be less than 54 millimeter. Aortic dimension in any spot shouldn't be more than 38 millimeter. Some places they take it as 40 millimeter. It's dependent of which center and which doctor you work with that. But as a standard is 38. If it's over 38 millimeter aortic root, it will be abnormal and dilated. The other number is 40 for left atrial axis in the PLAX, short axis of the valve should be less than 40 millimeter. And the last number is 60 for both genders is the same. This 60 is for long axis of the left atrium in the apical and the same 60 is for left atrial volume, 60 milliliter. So in this way you can memorize these numbers very easy. There are two most important parameters that we have to remember and we use based on body surface area. As you know, many of those measurements depend on body surface area. Those two important parameters is, one of them is left atrial volume index and another is left ventricular volume index. The normal left atrial volume index should be less than 34 milliliter per cubic meter, and for left ventricular volume is 75 milliliter per cubic meter. Those numbers usually we use based on body surface area. We have to calculate it, or when we put the height and weight of patient, the machine calculates us on the report. After we're done with the measurement in 2D and M mode, we go for the color on the mitral and aortic valve. First, we start with mitral valve. Again, I am emphasizing here, for catching any abnormal blood flow in any valve, we always should survey and sweep and scan all the way surface of the valve. So when you are focusing on a mitral valve, you have to fan your probe left and right and a little heel toe until you get it nice image and jet, if you can catch it, if there is any. Our color box should be small as possible, just cover that area and jet. The height of the color box doesn't affect too much on the frame rate, but the width of the color box is affect a lot. If our width of the color box increased, frame rate decrease and sensitivity of our image will decrease. So we just make the size of the color box that area, interest area. In the cases that we have any jet is not clear on the color, how it function and what is the mechanism of that jet, we can use a dual image. It helps us exactly what is going on and what is the reason for that jet, but it's not mandatory. After mitral valve we go for aortic valve and put color the way that cover some part of the IVS, aorta, wall, aortic valve, and part of the mitral valve, and should have a little LVOT. After finishing with the color and the same maneuver we do for checking any abnormal jet and blood flow, we go for the right ventricular inflow tract or tricuspid valve on PLAX. For getting this image or view, we just need from PLAX fan or angle tip of the footprint of the probe toward the right of the hip of patient. Sometimes even with a slide a little medial, it can give us RVIT. Depending on the position and body habitus of the patient, you have to be flexible and see which one works for getting good image. Sometimes even if you don't see very clear both anterior and posterior tricuspid valve leaflet, just twist a little counterclockwise or clockwise. You will notice more clear tricuspid valve very easy. The structure we will see in the RVIT view is part of the right ventricular here. We will see anterior and posterior tricuspid valve leaflet. Here we can see a little of coronary sinus, opening of coronary sinus, a little of the IVC. Sometimes you see a little bit more prominent, more obvious, and then SVC here. And this is right atrium. Here we have tissue, some part of the liver, and we don't see any part of the left ventricular. After we get in 2D, we put color on this valve again, and then we follow the same rule, sweeping and scanning all the way off the valve, and if try to get and catch any abnormal jet at that area. If we have any jet, we put cursor over that jet. If not, we just put it there at the center of the valve, and then we do continuous wave on the tricuspid valve. If there was any jet, then we measure the maximum velocity of the jet. In some center, they request do pulse wave Doppler on the tricuspid valve too, but it's not mandatory, and actually there isn't any guideline for using pulse wave for any evaluation of the osteric dysfunction of the right ventricular. After RVIT, we do RVOT, or right ventricular outflow tract, or better we called it pulmonary valve. We have two types of the pulmonary valve, two view for pulmonary valve in PLAX. One of them is modified. When is modified means that on the PLAX, we just twist slowly our probe clockwise, 10 to 15 degrees. And all suddenly, left atrium disappear, and here RVOT become open completely, and we will see pulmonary valve here and part of the pulmonary artery here. Here we can sometimes with the heart contraction or breathing of the patient, it change, but here we have IVS, we have anterior mitral valve leaflet, posterior mitral valve leaflet, some part of left ventricular, and even aortic descending here, maybe we see or not. This is a cross section of the heart at the this RVOT view, modified pulmonary valve, exactly the same. Those structure, we can see it in this real cross section of the heart. Another view that we use for catching the image of the pulmonary valve or RVOT on PLAX is non-modified pulmonary valve view. Non-modified means without any twisting, anything from the PLAX, we just fan tip of the probe toward the left shoulder of patient. If with this maneuver we don't get it pulmonary valve, just slide a little millimeter to the midline along the short axis of the footprint, and then angle to the left of the patient. And suddenly we will see RVOT here and pulmonary valve and pulmonary artery. I called it upside down eggplant because in almost all patients in non-modified pulmonary valve, it looks like this. We don't see any other structure here, just we see part of the RVOT, pulmonary artery and pulmonary valve here. In any of those that we got for pulmonary valve, we put color on the, here we have the schematic of the image that we get in non-modified pulmonary valve on PLAX. We just fanning to the left of the patient, and we cut a ultrasound plate wave pass through this line. After that, we put color if there is any abnormal jet on the valve. We catch it, record it, and then we put continuous wave on exactly over that jet. Here you see the jet. The most important character of the PI is that jet start at the level of the closing pulmonary valve, because at this level we have sometimes coronary artery pass through this area, and it give us some positive jet, and we make us confused. Is that jet belong to the PI or no? Is the blood flow from the coronary artery? Just look at the relationship starting of the jet and pulmonary valve. It exactly start at this level, so we know that is pulmonary insufficiency jet. Then we put cursor, and if we have clear envelope for PI, then we measure end diastolic and peak diastolic of the jet. After that, we put pulse wave on the level of the pulmonary valve, and if there is any reason for suspicions of pulmonary hypertension, we measure acceleration time at the beginning and peak of that, and the time between the beginning to the peak will be acceleration time. After finishing PLAX, we go for the PSAX or Parasternal short axis view. If on the PLAX our aortic valve be at the center of the image, just with twisting 80 to 90 degree clockwise from the PLAX, we get basal view at the level of the aortic valve view, PSAX of aortic valve. We will see that during systole open and during diastole closed, and it gives us the Mercedes sign, as you see here. Those cusps, we have three cusps, how we name it them and recognize them, each of them. Our landmark is Intraatrial Septum, IAS. Intraatrial Septum, this is left atrium, this is right atrium, and this septum, hyperecho line, at the center is a little thinner, is intraatrial septum. The one that connected to and is close adjacent to the intraatrial septum, it will be non-coronary cusp. So this is non-coronary cusp. This will be right coronary cusp at 12 o'clock almost, and 3 o'clock or 4 o'clock will be left coronary cusp. Other structure that we will see at this view, PSAX at aortic valve, is left atrium, descending thoracic artery that goes posterior to the left atrium, and sometimes you will see left atrium auricle or appendage, as you see here in this cross section of the heart, this reverse L shape, as you see here. This one is left atrial auricle or appendage. Sometime maybe we'll see left lower and upper and lower pulmonary vein here. We see upper here, but I don't see here in the lower. But it's not too much important in this image. Then we have here tricuspid and pulmonary valve here. After our image is only focusing for aortic valve first. So after we find out exactly, show all three cusps, then we put color over the only aortic valve, and we record it, and we try fan up and down and see is there any jet or not. As you notice here, jet insufficiency means during diastole. What does mean? Means when those three cusps are closed. So if you look at this patient has trivial, very teeny jet during diastole when closed. Very small, teeny blood flow you will see here at the center of the coaptation, all those three cusps. So we can catch it any jet if there is. After aortic valve, we go for the tricuspid valve. Before I go for tricuspid, I have to mention something, and that is about the aortic valve. When we have any abnormal structure or finding in aortic valve, like calcification, jet, or anything, always we have to zoom in at the aorta. We use zoom in, and it's better use dual image for finding exactly what's going on the valve, if there is any abnormality or not. For tricuspid valve, just from the aortic, we need fan without any twisting angle. We just fan the probe from aorta when we got it, fan to the right of the patient or right hip. In that case, tricuspid valve will very clear show up. If it doesn't show up, just a slight millimeter, a little down, angle up, or opposite way, slight up, angle down, or a little around that area with searching circular in that spot with fanning and angling to the right of hip. Tricuspid valve and right atrium show up very clearly. We have here posterior and anterior and posterior tricuspid valve leaflets. Then we put it color over the over the valve, and if there is any jet, as you see here, in one moment there is a small jet. We put cursor at that spot and do continuous wave, and if we can catch any jet during systole, as you see, we measure maximum velocity of that jet. After finishing with tricuspid, we go for the pulmonary valve. For the pulmonary valve, we have to fan toward the left of the patient, opposite of the tricuspid. From the aorta, we fan to the right of the patient, to the right hip. Here, for pulmonary, we fan to the left of patient toward the left shoulder. And try, when you start showing up, if you want to open completely pulmonary artery and even the saddle of the pulmonary, this spot that is branching, divided pulmonary artery to the right pulmonary artery and left pulmonary artery, just twist a little more clockwise, or suddenly you will see those two branches of pulmonary artery. When you saw very well the pulmonary artery, then we put color on that. With pulmonary, you can see here we have very nice feeling of the pulmonary valve and pulmonary aorta, and even right and left pulmonary artery branches. If there is any abnormal blood flow, PI, we just put continuous again at that spot, and we do continuous way. Sometimes if you need it, show more for any reason, for example, there are suspicious pulmonary embolism in the main branches, we can get a little fan, a little angle more up and twisting more or less. We can show more deep on those branches, left pulmonary and right pulmonary, more distal, and find those spots. In those cases that the patient has a symptom and sign of pulmonary hypertension, or we will find during our study, we will find that RVOT and pulmonary artery looks a little enlarged. In those cases, we have to measure at least three diameter. One RVOT 1, and the second one RVOT 2, and finally pulmonary artery. For RVOT 1, that is the same, we measure RVOT on the PLAX. We at 12 o'clock, we put cursor at 12 o'clock, inner at the largest diameter, inner to the inner of the aortic wall, inner to inner at this spot, perpendicular, and at 12 o'clock. For RVOT 2, we measure at the level of pulmonary valve, and for pulmonary artery 1 or 2 centimeter beyond the pulmonary valve, the spot that is very clear, has clear border, we measure those spots too. Sometimes even if we have clear branches left and right, we even measure those branches diameter too. Here the measuring the end diastolic and peak diastolic of the PI. And finally, again, we do, if we didn't do before, here we do it pulse way on pulmonary valve, and we measure acceleration time. After finishing pulmonary valve, we go for the mitral valve level. For mitral valve level, from the aorta, that spot, we just need a little slide or angle toward the apex. Slide or angle a little toward the apex, and all suddenly mitral valve starts show up. A correct short axis of the mitral valve view is the one left ventricular is completely almost circular, and we will see both anterior and posterior mitral valve leaflet and give us an impression of fish mouth. We called it fish mouth because it looks like that. And if is not closed completely left ventricular in any spot, it means we are twisting less or more. Just with twisting more or less, it start closing any spot that is not closed. Sometimes with sliding it help us. That make it left ventricular at the level of the basal mitral valve should be completely circular shape. Then we put color on the mitral valve. As you see, we have a little jet at here at this spot during systole. So we catch it that one and show it. After mitral valve color, we go for the papillary muscle level. Again, there is the same concept and principle. Left ventricular should be circular shape if there is any wall motion abnormality, of course. You will see the wall are moving, but shape should be circular shape. If it's not closed, again, there are two reasons. We are twisting less or more, or we are off axis. Off axis, and our left ventricular at the level of papillary muscle is not circular shape. In another reason it cannot be circular shape is when pulmonary pressure is very high. In that time, the IVS become flat and give us the D shape during only diastole or systole and diastole. That is different topic. We are going to talk about is in pulmonary hypertension. There is one important technique for getting correct PSAX on left ventricular at the level of papillary muscle. We have two techniques, sliding and angling. The correct way, when the heart is almost vertical. So in the regular people, and those are tall and not fat, and heart is more vertical, not horizontal, is more vertical and not bented. The best technique from the aorta to the apex is that we slide the probe toward the apex for each level. In those cases, if we just angle it, we get off-axis image, and it not will be instead of the being circular shape, it become oval shape, and that is the reason we don't get circular shape, and we know we are off the axis view like this. But in those patients on the PLAX, you will see that apex, tip of the anterior tip of the apex is too much anterior to the wall, and heart is almost horizontal. In those cases, you can use it just with fanning, not sliding. With fanning, we can get it good image at those three levels of the left ventricular. Okay, the next one is for the last one for the PSAX is apex. For apex, as you will see here, I can say this is off axis of apex, and this is correct one. Why? First of all, this, if you notice, this is oval shape. Second, apex, if you are in the right axis and we get in correct image, apex twist counterclockwise like this. But this one just a radial contraction. This is off axis, this is correct axis, because this one has been angling from the base to the apex. This one has been slide to the apex, and we are right axis at this level. Another one that I like to mention here before I go for the next slide is aortic ascending aorta. Whenever you doing and getting image PLAX and checking on the aorta, always try for yourself, go slide toward the aorta and catch the and check ascending aorta, make sure there isn't any pathology at the ascending aorta. Even it's not mandatory in our protocol in the transthoracic, but always do it, and you will be surprised many times there is some pathology, especially aortic aneurysm at the ascending aorta, that in the PLAX view, standard PLAX view, we don't record it. We have to go a little off axis, slide our probe toward the midline to the aorta more, and maybe twist a little clockwise more and see ascending aorta. Before I finish the PLAX and left parasternal view, I want to mention about right parasternal PLAX. As I mentioned, right parasternal we can use in some patient for that study. For getting right parasternal, we have to turn the patient to the right side and right arm up, and instead of putting the cursor perpendicular to the chest, we pointing to the right hip of the patient, left hip of the patient. So, and we start from second to third intercostal space next to the sternum, and pointing to the left hip of the patient, and with maneuver searching circular, we can get it good, most of the time, good ascending aorta, sometime off axis of the PLAX, and most of the time four chamber view of the heart from the right parasternal. And if we twist it clockwise, we can get it the base of the heart and left ventricular short axis. Those images, in many cases, it help a lot, especially for ascending aorta and for checking IVS when we don't have good image in subcostal window. I hope you like this lecture, and if you thought this was useful, please share it.